Very good evening to everyone. I'm just trying to start I'm just going to present this case. I mean, rather, it's not a presentation in terms of to tell anything, just to discuss the things because I'm a bit curious about. I'm just a first year resident doctor here, MD medicine, and this is a very incidental finding we got in this case, and then that's why we were talking to our professors like to discuss this case, and we got this best platform like where we can talk about, and we can get best opinion as well actually. Okay, I'm going to start now. This is the case we got a 34-year-old male, which is from a local district here. And he admitted here in our hospital on 23rd of January and discharged on 1st of February last week. He admitted to us with a complaint of short of breath, dry cough, and headache for last 1 week. And I should say, like a history of present illness of the case was he was admitted like 6 weeks before in a local hospital with a similar kind of complaint, cough and short of breath for 1 week. And there he diagnosed with bilateral atypical pneumonia with COVID-19 RT-PCR negative. But however, his HRCT severity score was a 21 out of 25. On the basis of that, like which diagnosed bilateral atypical pneumonia, and he was discharged on 15th of January on oral antibiotic, and then came to us actually with the same complaint with a headache add-on for last 1 week. But there was no significant past medical history in this case. And when we did examine on the admission, there's no pyelorectus, cyanosis, clubbing, lymphadenopathy, pedal edema, and vitals was quite normal actually. The blood pressure was 124 by 78, and pulse rate was 88 per minute. Respiratory rate was 22, and saturation was maintaining 98% on room air. Then we did systemic examination, as in he was very conscious and like completely oriented to time, place, person. And respiratory system wise, definitely there was coarse cracks in both the lower zones, both lobes. But CVS point of view is like there's nothing significant as such, quite normal as one as two audible. There's no added sound. Abdomen wise, so it's quite soft, non-tender. And when we did initial investigation at our place, uh, completely normal within range CBC, LFT, RFT. Even we did find RT-PCR we repeated here in last 2 weeks before 25th of January, which was negative. But definitely there were few inflammatory markers on raised, and I should say D dimer was 4,000 at that time, at the time of admission, and we found gram-positive cocci in a sputum gram staining. And when we repeat here HRCT chest, we found the score 13 out of 25 on 23rd of January. And the same time, because as a moderate protocol was started for COVID treatment, we did ECG and 2D echo here. And that the story start from here now. With the ECG was quite normal sinus rhythm. And then we did echocardiography with our team, expert team here. And we did found a mass in right atrium, measuring 1.2 centimeter by 0.92 centimeter, which was showing like attached to the interarterial septum. There's a multiple mass we found. In right atrium is a bigger size, you can see, in the smaller one, in the left atrium as well. These are pedunculated masses, and I can show some few more pictures. These masses you can see, I think everybody can see very well. Then we did this color Doppler as well. There's no problem with the flow. We can say like superior vena cava flow, SVC flow was quite okay. This one. And then we did put some videos. Okay. A few more videos we did. Here we can see like multiple mass are moving. Here, the big one, the biggest one, I should say. We did again the color Doppler. It's like flow was quite very well. It's not hamper anywhere. The bigger and the smaller, and the left atrium as well. The multiple masses. Here it is. Okay. On the basis of this, my keen interest is to know, like we got reported from here from our department, but that's a my thing. Like I just need to discuss here in this platform where the experts are here, and just to discuss about, because we didn't find any clinical finding, just mainly on the basis of this 2D echo. It's a turning thing for that patient. And that's why I didn't write the impression here, but I can show you the report. But just want to start with, like, if panel can advise on these findings basically, and what exactly they think, like, because we found these multiple masses like in right atrium in the left, which is pedunculated to the interatrial septum. And then I can proceed further. I mean, I don't know it's the right way to do it, but I we can proceed further, like we can show what we did further after this. Is that okay? I mean, I'm just asking to the panel, is that okay to talk about on this basis, so we can discuss, we can get the opinion from the panel?
Is there any mass in left atrium also? No.
Yes, yes.
So both in both the atria there are masses.
Both exactly. Right atrium, the two masses we found, and the left as well, one small one.
Small masses.
On the basis of 2D echo.
Yeah, this is not real.
Yeah. I mean, the other thing is, like, when we were talking about, when we got the report from our echo department, I mean, cardiology department, and then it's definitely thinking like vegetation, or is it, I mean, thrombus, or the finding was like thinking about the bilateral myxoma.
Yeah, so if I can comment, this is Dr. Sengupta. So as you said, the COVID was negative, but the D dimers were high. I mean, there were some patches in the lungs also. You mentioned some scoring system.
Yeah.
So I think it is a COVID-like symptom in our setting. So it's a hypercoagulable state, and there are now reports that there is a good association, around 40 to 50% of association of COVID with C-ANCA and P-ANCA, antiphospholipid antibody. So I think, did you do lupus and ANCA and P-ANCA in this patient?
Not exactly. When we found this multiple, like, I mean, differential diagnosis on multiple bilateral myxoma thing, and then they advised us for the cardiac MRI, and then we went for cardiac MRI actually.
Yeah, I think Partho is also there. He can also comment. So multiple masses in a COVID-like situation.
Yeah.
Yes, so I just saw the images. My first impression would be to think about presence of a patent from an ovale with a thrombus caught in transit. Just the linear way, just extending multiple masses, that will be the one unifying diagnosis. I mean, you can always entertain other possibilities, but that will be my highest suspect. So I would suggest immediately, if it was the images were not clear, I would do a TEE and see, what is the extent. And number two, I would do an ultrasound examination of Doppler assessment of the extremities to see if there are any thrombi in the venous system. But if you see any thrombi in the venous system, then you have. I mean, the best way to explain is clots are moving up. Some have gone into the lungs. Some have gone across and trapped across the PFO.
Yeah. Dr. Goel, did you actually do a MRI?
Yeah, right, exactly. We did the cardiac MRI actually for this patient, and it's reported there. They were saying it's only right atrial myxoma, the small pedunculated right atrial myxoma. I can share the film if you want to see the film of
Yeah,
MRI.
please. And what about the left side? The same thing?
They didn't comment anything on the left. They just measure the size of this one big one, 13 by 11 in the right, basically right atrial myxoma, which is attached to the IAS. And
But your presentation of the patient was with fever.
Patient was presented with short of breath, not exactly fever. He didn't get
So
fever.
did you do a CT pulmonary angiogram to look at the pulmonary arteries?
No, because the thing is, because patient symptomatic was relieved and then it's very low economic patient and want to get discharged. But we just reported this myxoma and then we did refer to the higher center in terms of the cardiac surgeon, CTV surgeon.
No,
So,
but was it related to, can you explain this on the basis of the right atrial myxoma, the dyspnea part of it?
Patient was on definitely short on breath, but the thing is, when we did examine, we didn't find any polyp sound or anything. Like usually in myxoma, they were saying if the size is bigger size, then we found as a polyp sound on during mid diastole or early diastole. But clinically, we couldn't justify this. I mean, the only basis of investigation.
So you'd like to say it's an incidental finding?
It is actually because it's not related at all. I mean, it's the definitely incidental finding. And after that, we are chasing the case because when we referred him to, we just discharged on first, and the appointment is next week for the cardiothoracic surgeon because there's no symptoms. That's why it's like, I mean, he was not very much eager to do anything, but we explained and did the counseling as well. And we did refer the patient to the higher center. We'll definitely chase it.
So, Dr. Goel, if you show the intraatrial septal mass video one more time, I'll tell you why I'm thinking about high likelihood of this being a thrombus in transit. Again, things are always possible, but common things will be common. So this being a clot in transit is entrapped across the. So look at on the left hand side. See, it is not like a mass. It's more like a linear.
Yeah. It appears to have passed through a PFO.
Yeah, so it is, and it is multiple lobulae. I mean, it's not a single large mass. It's got linear trends. So these are almost like look onto the left hand side. See, it's a linear thing. So I would examine very closely the PFO area. I mean, the septum, and it's right across in the septum going. And again, malignant masses, I mean, in myxoma and all those is possible. Look at the right side. Right side is dilated. Look, the right ventricle is dilated. The patient has shortness of breath. So some might have gone to the pulmonary circuit. Something is going across the PFO. That will be a unifying diagnosis. After that is excluded, this common diagnosis is excluded. Then you can move on to the others. And again, I wouldn't just go blindly by what MRI is saying because it all depends upon who is reading and what they're reading.
Yeah, true.
So,
was there pulmonary arterial hypertension? What was the TR gradient, by the way?
No, it was not actually. I mean,
again, pulmonary hypertension doesn't happen all the time in pulmonary embolism.
But since the RA and RV appear to be dilated, I'm slightly skeptical about the view. But RV definitely appears to be little dilated.
Yeah. So
just I want to share this.
Thromboembolism is still high on our minds. Anyway, so I think it is time for Dr. Sarkar. Any final comments? Yeah, you are there with the.
This is the MRI film, like where they indicated the arrow.
Yeah, even here the RV looks little dilated. Dr. Sarkar, your final comments on the case?
No, RV is almost the size of LV.
Dr. Sarkar, are you there?
So here, I'm here. Echocardigraphically, the mass doesn't appear to be a myxoma actually. Impression is much more on rather thromboembolism or vegetation. Somehow this is echocardic impression.
Okay.
Have you already referred the patient to the surgeon?
Yeah, we already referred to the higher center. That's why I'm saying like the appointment is the next week. Like that's why we are chasing the case. And on this basis of report of this MRI, like contrast enhanced cardiac MRI, and they said like it's a right atrial myxoma. On that basis only, we we refer to the higher center for cardiothoracic vascular surgeon. And we'll definitely chase this, but we thought like we got this opportunity to discuss it here so that we can work
Yeah.
upon, I mean,
I would give a course of anticoagulation and a follow-up echo before the surgeon opens up, because that will be a mistake if it's a clot.
And a CT pulmonary angiogram is indicated. Before you
Right.
send the patient to surgery, please do a CT pulmonary angiogram. Anyway,
Right.
in fact, on your list of mentors, I could see one of our old friends from Kolkata, Dr. J.C.
Okay.
Sharma.
Yeah, yes, yeah.
Yeah, and thank you for presenting the case all the way from Udaipur.
No, thank you, really. Thank you to the panelists to giving me this opportunity to talk about this. Thank you.
Nice. Thank you very much. Dr. Sarkar, your final comments and we'll close the session.
Regarding Dr. J.C. Sharma, he was very close friend to me. Okay, so
Okay.
my best of my wishes to him.
I will definitely convey to him. Sure. He's like our mentor here in cardiology. Thank you.
So, Dr. Sarkar, shall we say good night to everyone and close the session? Okay, thank you. Thank you all the presenters for a marvelous job that you have done. Congratulations. And thank you.